Anemia is so common in women worldwide, especially iron deficiency anemia. And I'm wondering, once you have a patient who has heavy menstrual bleeding, really what your next steps are and how often you're doing a broader diagnostic workup.
I'm always thinking about like, does this person have a Willebrand disease? Does this person have another underlying bleeding disorder? So family history can be helpful. Obviously, other like bleeding history can be helpful, but in and adolescents, a lot of them have never had surgery before or haven't had a baby to know if they're going to have postpartum hemorrhage. But adolescents who are anemic from their period probably need at least some workup. In adolescents, the most common causes of heavy menstrual bleeding are anovulatory cycles, coagulopathy, more things like that versus like structural causes that you would think of in older adults where you worry more about things like malignancy or endometriosis, those sorts of anatomic things that you don't see necessarily as much in adolescents.
Are you pretty routinely sending these coagulopathy tests? And if so, like which tests do you tend to send?
It would depend a little bit on like how severe things were. So I've had patients that there was really nothing else leading me to a bleeding disorder, but they came in 6 months into menstruating and their hemoglobin was 4. Well, that's just really, really abnormal, right? And so I would send testing in those patients. The testing is tough because we actually recently did a study where we looked at whether just being severely anemic could affect your von Willebrand's levels. So we have patients who come in and their hemoglobin 6 and their von Willebrand panel is completely normal. And then when we get their hemoglobin to 13, they clearly have von Willebrand's disease. And whether that's some stress response or some other mechanism, we don't really know, but it can be tough because oftentimes, even with people who have really severe anemia, they don't necessarily see hematology. And so, I actually been working on kind of a pathway for our ER for adolescents coming with heavy menstrual bleeding. And I think we're going to end up just having them not send the test because it can give you this false sense of, oh, they've been worked up and they don't need it.
Remind me again of like the common coagulopathies that you're thinking about.
Sure. So if you're just screening for factor deficiencies, you can send a PT and a PTT, but the PTT can be normal with a mild factor deficiency. So depending on your level of suspicion, you can send individual factor levels. So it'd be like 9, 11. And then from Willebrand's factor panel, you get factor 8 with it. Some studies in adolescents have shown that platelet function disorders are actually more common than von Willebrand's disease as far as an etiology, but at least at our hospital, it can only be ordered by hematologists and can't be done inpatient. But I think that's another reason why you have someone that has had, especially severe enough bleeding that they needed a transfusion, they really should see hematology at some point.
Speaking of tests that were abnormal in these patients, one of your papers talks about that some of these patients can actually be more coagulopathic when they're iron deficient. And I'm wondering if that's something that you've seen borne out clinically.
There are many reports in the literature, and we've definitely seen this clinically of iron deficiency being associated with like CSVT or clotting in your cerebrospinal veins. And that can be devastating. When we think about iron deficiency, it's just like iron deficiency, like you take some iron and you get better. And it's so true. Like it's one of my favorite things because of that, right? Like you can make people feel so much better. It's like we have a good treatment. If you don't tolerate oral, we can give IV. People shouldn't die from this. But sadly, that can happen.
In someone who has heavy menstrual bleeding when you sort of expand that search and wonder could something else be going on?
That's a great question, and I think this has come up for me most commonly when it's those patients who I just can't seem to figure out how much they're bleeding. Maybe we're treating them and they don't seem to be getting better as quickly as I hope. It's easy to send celiac testing or it's easy to send, H. pylori or those sorts of things, but less easy to say you're gonna go and have endoscopy and colonoscopy, not to mention getting someone in to get a scope is gonna take a while anyway. And oftentimes what I end up doing is saying, I would like to stop your periods entirely for some amount of time so that we can say one way or another, right? There's like a proportion of patients, and oftentimes, like it's more the parents than the patient that are like, I think you're supposed to have periods. That's not normal to not have periods. But then as soon as they do it, especially the adolescent, it's, I never went for a period again. This is amazing. So if we can do something like that for even just a period of time, I can clarify things.
And then if you're taking iron and it's still dropping, yeah, what's your threshold to be like, wait a minute?
That's what makes this all so hard, right? There's so many factors. It's not just how heavy your period, it's also what are you eating and how much of that are you absorbing? Are you taking your iron with coffee or tea? Are you taking your iron with milk? There's just so many things. And really, if you delve into the literature, of what inhibits iron absorption, don't ever look at that because you can't have anything. like around and every individual is going to be a little bit different. And 70% of people who take oral iron have gastrointestinal side effects. And so most of the people who are taking oral iron are probably not s- the most compliant all of the time.
I thought the preparation stuff was so interesting, like just learning about enteric coated iron and how it sounds great. And it's just slow release iron that sails right past your duodenum and doesn't get absorbed.
That's the thing. And then I have so many patients who are like, well, I didn't tolerate the one, so I got this other one. And then when they bring it to me, it's like, there's no iron in this. There's like this whiff of iron. And I'm like, this is nowhere near what you need to get. So I think it's really challenging because there's all of those things that kind of play into that. And then we just don't do a good job of actually quantifying, how much blood you're losing. So that's when often I will do IV iron when I'm like, I don't know, you're taking this. This isn't getting better. And sometimes we'll do an iron challenge.
What's an iron challenge?
So you have them come in fasting and then they get baseline iron panel and then you have them take like a normal dose of iron and then you check an hour to 90 minutes later and it should go up substantially.